Hello, everyone, and welcome to today's keynote webinar titled Assessing the Impact of Medical Cannabis on Autism Using Pharmacometabolomics on Machine Learning. This webinar is a part of the 7th annual event in the Cannabis Sciences virtual event series. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots. Before we begin, I would like to remind everyone that this event is interactive, and we encourage you first to participate by communicating with other attendees using our live chat feature during the presentation. You can find the live chat located at the bottom left of your screen. You can also participate by submitting as many questions as you would like during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Help Desk button from the lobby within the event. Finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the continuing education credits image located on the right of your screen and follow the process to obtain your credits. Now let's get started. I'd like to present today's speaker, Bonni Goldstein, Medical Director of Canna-Centers Wellness and Education. For a complete biography on our speakers, please find it on the left of your screen. Bonni, thank you for joining us. You may now begin your presentation.
Thank you so much, and thank you for inviting me to speak. So I'm going to be talking about some research that I've done over the last, let's say, 4 or 5 years, and all of the papers related to this research are free and open source online. And certainly if anybody has any questions, I'm more than happy to answer at the end of the presentation. So we'll just get started. If you're not familiar with me, I am a California licensed physician since 1991. I trained at Children's Hospital Los Angeles and specifically worked in pediatrics. And once I finished my training, I was chief resident for a year, and then I went into critical care transport medicine, a bit of an adrenaline junkie when I was younger. And then in 2007, 2008, I had a friend who was ill who asked me about medical cannabis, and I didn't know anything despite the fact that we had had a law here in California at that point for about 12 years. And I became interested in doing some research for her, and I was quite intrigued, and I was looking for something else to do, and I've been now working in the cannabis specialty since 2008. And my disclosures are I'm medical director and owner of Canna-Centers, which is my medical practice. I have a new company opening, CEO and co-founder of Goldstein Wellness. I'm a board member for the International Alliance for Cannabinoid Medicine, and then I have a few paid consulting gigs, clinical advisor to Canformatics. That's who I did this research with, and medical advisor to Weedmaps, and also medical advisor to the CanMed 2024 conference. So those are my disclosures. The learning objectives for today. So number one, we're going to define pharmacometabolomics and its potential to objectively measure the impact of medical cannabis treatment. We're going to discuss pharmacometabolomic applications, including predictive, responsive dosing guidance, monitoring, and diagnostic capabilities. And also, I'm going to explain how identification of biomarkers by machine learning may lead to better understanding of the uses and impact of medical cannabis. So first, I'm going to start with just an overview of autism and the challenges that it presents in terms of treatment. So we know that autism has become quite prevalent. It's unclear if we're just diagnosing it better or if we actually are seeing more cases. I believe it's both. About 1 in 36 children will have a diagnosis of autism based on reports from the CDC in 2023. That's up to 2.8% of 8-year-olds. We know that boys are more affected than girls, about 4 times more likely to get the diagnosis. And we talk a lot in the autism community about core symptoms. And so these are symptoms that are difficult to treat with the current treatment modalities that we have. So one is communication difficulty, not for everyone, but for some, impaired reciprocal social interaction. And the third is restricted, repetitive, and stereotype patterns of behaviors or interests. This doesn't completely sum up what's happening. We know that children with autism have increased neuroinflammation and neuroimmune dysregulations. And we also know that they have gut issues that are 4 times more prevalent than their non-autism counterparts. And when we think about the endocannabinoid system, which remember is the system where cannabis interacts in the body, which is everywhere in your body, just about the main areas where there is high density of cannabinoid receptors is brain, gut, and immune system, which overlaps with patients with autism. And we have lots of challenges. These are the symptoms for which people seek my help with cannabis. So insomnia, aggression, anxiety, self-injury, impulsivity, inattention, sound sensitivity, and also OCD and hoarding, which I do see quite a lot of. And then before I move on to the next slide, I just want to point out that right now we only have 2 FDA-approved medications. Both are atypical antipsychotics. They are approved to treat, quote, the irritability of autism. So really they're addressing mood. They're not necessarily addressing core symptoms. And we currently, again, do not have medication that is addressing core symptoms. As many of you know, atypical antipsychotics have terrible side effects for many. Weight gain. I have seen patients gain 40 pounds in 3 months time frame on these drugs. And then you have just a larger child who is still aggressive, which can be very difficult for the family. We also know that you can get metabolic syndrome, diabetes, hypertension, breast growth, and some other unfortunate side effects, tremor. And just, there's always this question of what are the long-term side effects if someone is on these for many, many years during these crucial developmental time. Now, why would we consider cannabis? And again, I've already mentioned there's a nice overlap, but the endocannabinoid system is known to regulate behavior and emotion. It also controls the pathophysiologic mechanisms producing neurobehavioral deficits in autism, and this has been researched. We have this immune dysfunction, metabolic disturbances, and aberrant synaptic plasticity. And remember, the endocannabinoid system exists to promote homeostasis in these areas, to have balanced messages. And then we know that dysfunction of the endocannabinoid system is associated with the pathology of neurodevelopmental disorders. So it becomes a interesting target for treatment for these patients. The first report in the scientific literature comes from 2010, where a couple of researchers gave dronabinol. So remember, dronabinol is synthetic THC. In a single case study in a child who was 6 years old who had difficulty from autism. And the aberrant behavior checklist before and after treatment with dronabinol, as you can see in the top right graphic, was used to assess the outcome, the total daily dose. Now, they started with just drops of the dronabinol 3 times a day, starting like with 1 drop and titrating up. The total daily dose is 3.62 milligrams, which, if you're familiar at all with THC dosing, usually in children, we start with 1 milligram, titrate up, although some children need very high doses. Most of these patients can do well with low, non-impairing, non-intoxicating doses. And in this case, this child had no adverse effects and showed some significant improvement, as you can see with the subscales from the aberrant behavior checklist, from irritability. Oh, and this is over a 6-month period, went from 38 down to 13. Lethargy went from a scale of 23 down to 11. So these are very significant numbers. You can see hyperactivity was cut more than in half in terms of the scale, and inappropriate speech went from 6 down to 0. And then the graph shows just the dramatic decrease in symptoms. And so this, again, was the first report. And since that time, we have multiple reports of using cannabis in trials. Most of these come from outside the United States. And many of them report benefits between 60 and 90% rate of benefits in the patients that are the participants. Interestingly, what has been found, there's two studies, one from Stanford University, published in 2018, which is Carson et al., published that children with autism have lower levels of anandamide compared to their non-autistic counterparts. Anandamide is one of the main endocannabinoids that functions to maintain homeostasis or regulates neurotransmitter messages. And so if you have low levels of the regulator of your neurotransmitters, that can manifest as difficulty with emotion behaviors and insomnia and some of the other things that we see for these children. A repeat study was done, or a second study was done in Israel in 2019 by Adi Aran et al. And he also showed that children with autism have lower levels of circulating endocannabinoids. So basically, the way that we look at this now is that this is an endocannabinoid deficiency. And this concept was hypothesized in the early aughts by Ethan Russo, a neurologist and cannabis researcher. And we have some understanding that by giving children cannabis, the idea is that we are replacing the missing or deficient endocannabinoids. And so the big question becomes, in practice, how do we corroborate parental reports? So when parents are telling me my child is less aggressive, my child's sleeping through the night, many in the medical community look at this as anecdotal only. It is not evidence. And so how do we measure these outcomes objectively? Which cannabinoids will affect specific physiologic pathways? I mentioned dronabinol, which I don't use, but some people do. I will use THC, but we also have other cannabinoids, CBD, CBDA, THCA, CBN, CBG, all of these different cannabinoids that are now readily available, and people are using them. And so how do we sort out which cannabinoid might be beneficial for a specific patient? Also, can we predetermine cannabinoid response? What's really interesting with cannabis is that doesn't work for everybody. I would say in my practice with autism, I see about a 70 to 75% response rate where parents decide, yes, we like this, it's working, we want to continue. In my epilepsy population, I would say the number's a little bit higher, about 80 to 85% of parents report that they want to continue because they're seeing benefits. Can we predetermine, though, who might not benefit and save the cost, the resources, the effort, the time of these families? And right now, to be completely frank, when I am treating a patient, I use my clinical experience, I use the research that's been published, but ultimately it is somewhat trial and error. Now, I know we do that with a lot of other medications as well. We don't know how somebody's going to respond, but I would like to be able to have a path forward that is less tedious and clinician intensive, and also parent stress intensive in order to treat these patients. And so that leads me to my research. And these 3 papers are available online, open source, if you'd like to read them. And again, this was with a company called Cannabis, who has the IP and technology. And what we did was we decided to use pharmacometabolomics, which I'll explain, to evaluate the pre and peak, so before and after medical cannabis. And so what is pharmacometabolomics? So let's talk about that. So systematic identification and quantification of metabolites, what's also called the metabolome, in an organism or biologic sample. And this allows us to see and measure changes in biochemical pathways. This is well established in the scientific literature. It's used to research drug effects on individuals so that we can understand the action and metabolism of drugs and detect the factors that alter the breakdown of the drug. So for example, there's a couple of papers out there looking at a response to simvastatin, a cholesterol lowering drug. And because we all have very different gut-derived microbiota, we have different genetics and everything else that affects how we take drugs. They found that the gut-derived metabolites correlated to response to simvastatin. So what your gut is made up of affects how you might respond. And many of us might not know that. as we kind of hand out these cholesterol-lowering drugs, we really don't know who's going to respond or who might have more side effects. And so pharmacometabolomics allows clinicians to predict the response and personalize the treatment for a specific individual. And so what we looked at was salivary biomarkers. And the reason we looked at saliva is, one, it is a complex fluid containing metabolites that enter from the bloodstream, but it's functionally equivalent to serum in reflecting the physiologic state. And in this particular population of children with autism, it's an easy collection. It's non-invasive, it's low cost, and it can be done at home. And just to put an extra point on that, I have patients who cannot get blood work, don't get their teeth cleaned without anesthesia. It's just difficult because the children have so much anxiety and difficulty in new situations, and don't respond well a lot to these types of interventions. So the saliva collection was very easy for our patients. It was done at home. And what you can see in the graphic is that what we're showing you with the metabolites, I'm not sure if you can see my pointer, but all the way to the right, you see the metabolomics with metabolites. This reflects the phenotype, exactly what's happening in that person at this moment, as opposed to the genotype, which reflects the potential, which may not be expressed and may not be participating in what's happening at the moment. So it's an actual versus a predictive. And so the design of the study is we recruited 18 children, and ultimately 15 were included in the final report. They had to be on medical cannabis treatment for at least a year. And the reason that we decided to do that was because in the beginning, when we're starting, if we were to start, it would have been a much longer treatment, because remember, if I start somebody on something that doesn't necessarily suit their chemistry, we have to stop, and then we start with something else. So we wanted children that were having a stable response, where we could measure before and after medical cannabis dosing. And we had 9 controls. These were typically developing children without autism or any other neurologic symptomatology. And they established our physiologic range, which I will show you, for these metabolites. And so as you can see in the graphic on the right, the child didn't take any medical cannabis overnight for at least 8 hours. Now, some of them had longer than 8 hours because their last dose of cannabis was 4 o'clock in the afternoon, let's say, and they didn't take another dose until the next morning. They went 60 minutes without any food or high sugar drinks. They rinsed their mouth. The parents did a behavior survey. And that is because we wanted to see if our metabolite measurements correlated with what the parents were reporting on the surveys. The saliva sampling took place, and then they took their medical cannabis. That was what we called our pre. So that was before they took their dose. Then we repeated at the 90-minute, between 90 and 120 minutes or so. And we called that peak. That is when the parents said that they saw the change in their child due to the dose of medical cannabis. So for instance, calmer behavior, less hyperactive, less aggressive, better focus, better speech, those kinds of things. The biomarkers and the metabolites, I use those words interchangeably, they measured pathways involved in neuronal dysfunction, pain, aggression, the endocannabinoid system components, inflammation, bioenergetics, all compounds that have documentation in the scientific literature to be involved with these pathways. And so let me show you the makeup of the patient. So on the left-hand side, you see ID number. So that was the number assigned to the child. You can see the ages 6 to 12. Now, we didn't go below 6 because, again, a difficulty in obtaining a saliva. This is not a swab test. This is at least 1 milliliter of saliva that needs to be collected in a tube. And we didn't go any higher than 12 because we were trying to avoid the effects of too much puberty and hormones. But you will see that we did have some influence of puberty in those older kids in the results. As you can see, the gender is mostly boys. We actually I don't have that many girls in my practice with autism, interestingly. And then the dosage per day, and then the cannabinoid content to the right. This is all individualized, personalized regimen based on the parental reports. and developed over a long period of time. So if it says 2 doses per day, the child got a dose in the morning and at noon. If it's 3 doses a day, morning, afternoon, and evening, 1 dose a day just in the morning. And again, customized to their response and their needs. Under method, edible and tincture, basically all of my patients are on tinctures. However, when we say edible, it means the parents were putting it into food for them to take. So like a scoop of yogurt, they would squirt the oil into that, and then the child would take it by a spoon. Tincture meant that they were getting it squirted into their mouth. And as you can see, all the different cannabinoid listed there, all the different cannabinoids, lots of patients using CBD, THC, and some using CBG, and then just a few using some of the minor cannabinoids, CBN, cannabinol, THCA, and CBDA. If you're not familiar with THCA and CBDA, these are the raw cannabis precursors to THC and CBD respectively. And I have found that they can be helpful for inflammation and anxiety. And also sometimes for seizures. None of the patients here had the dual diagnosis of epilepsy, just to make that clear. As you can see, the doses really range from low to high. And again, in my practice, I go based on the child's response. No one is impaired, no one's intoxicated, and for the most part, nobody is having side effects. It is really a personalized response to give the child the optimal dosing without side effects. So this is the behavioral ratings before cannabis. So we use 3 validated scales that are used often to assess children with behavior challenges. And as you can see, it looked at attention, hyperactivity, aggression, and some other things. Red means that it's a higher rating. Blue is the rating is low, and then the colors in between. And as you can see, we have a lot of red. We also have some blue in there. So you can see some children, like for instance, I think it's A6 is just all red from top to bottom. So reflecting that the child is really severe. And then if you look at A12, not so severe. So the children were in different states. And again, this was on the day that we collected the cannabis in the morning. Collected the saliva in the morning. And at that time, what we got for the ratings was 11 children were severe, 1 child was moderate, and 2 were mild. And then just to show you the behavior ratings after cannabis, as you can see, there's quite a bit of improvement. So 11 children improved, 2 children had a mixed response, and 2 actually exhibited increased difficulties when we collected that saliva for the peak. Remember, so 1.5 to 2 hours after their medical cannabis. And it's possible that collecting the saliva created behavior because they were being asked to do something that they're usually not asked to do. And again, many of these children do have some rigidity or just do have difficulties when asked to do something that's not typical. But as you can see, if you look at the of those reporting symptoms all the way to the right, you see percent improvement, pretty high numbers of improvement, although we do have some with worsening and some with no change. But in general, this is what I see in my practice. These are my patients, and these are usually the results where we have a fair number of patients that show significant improvement. Now, this slide is showing you the typically developing children and basically how we determined what the physiologic range was for each of these metabolites. So we looked at the average, and this is in micrograms per deciliter, and these are the 9 patients, and this is where their metabolites fell. This is the average, so this is what developed our average or our mean here, and it's we determined the various standard deviations away from the mean. So what is kind of within normal limits? And I kind of think about that terminology similar to how we do blood tests. So if you have a white blood cell count of 4,000 to 12,000, that's within normal limits. If you're lower than that or higher than that, it tells your physician that you are having some difficulty somewhere until, of course, that's ruled out. And so what we determined to be symptomatic was plus or minus 4 standard deviations away from the mean. And so this was our reference, and this is what we used to determine where our patients fell before and after their medical cannabis. So now in terms of the findings, so for our metabolites, 484 known metabolites were detected in the saliva samples. 65 were identified as autism cannabis-responsive biomarkers, meaning they were found in 8 to 15 of the children with autism, and they changed in response to the medical cannabis treatment. 31 of these metabolites were detected in all of the participants, and 21 of these exhibited statistically significant change with a p-value less than 0.05 in the children with autism. So let me show you one of our results, one of our metabolites. So N-acetyl aspartic acid, so NAA, is a highly abundant neurochemical. It is the second most abundant chemical behind glutamate that is in the brain. It reflects neuronal density and viability and can reflect neuronal dysfunction. Both high levels and low levels have been found in autism. So some reports show that the levels are very low in autism. And in one of the reports that documented high levels, that was in patients with the previously used diagnosis of Asperger's syndrome or high functioning autism. And so what we found, let me show you the graph here. All of our patients are along the bottom, so A1 through A18, and then you can see that all the way to the right, the reference range of the typically developing. So that dotted line across shows you that average or mean. And what you can see here is the dark blue is before cannabis and the light blue is after cannabis. And what you see is that cannabis shifted almost all of these patients from either too low or too high NAA towards the physiologic mean. So we have A1, which is not too far outside the mean and doesn't qualify as abnormal, but it did come down towards the mean. You can see with A2, very high level that is shifts with medical cannabis towards that physiologic range. A3 did not have any detectable or very low detectable NAA. And then after medical cannabis, it shifts towards the mean. And so, of course, you can see this with, if it was low, it brought up. And if it was too high, as you can see in the older children, notice this, remember, these are the kids that are approaching puberty, if not starting with a little bit of effects of the hormones. They were all somewhat high, and the medical cannabis brought them down. And so ultimately, what we're seeing here is that medical cannabis modulated both groups towards the mean, suggesting stabilization of the levels. And really what this reflects is the homeostatic effects of cannabis treatment. And we've been saying this for years, that we think that intervention with some people having either hypo conditions or hyper conditions, both are actually homeostatic. And so here we have objective data documenting this, which I think is very exciting because, again, I trust the parents to give me the truth or what they're seeing with their child. I believe their reports because I don't see any reason for them to lie, especially with out-of-pocket medicine that is easily accessible now in most states. But this helps us understand what is happening with these patients. Here we have another metabolite called spermine. It's a polyamine essential for normal cellular function. It's involved in cell growth and proliferation, adhesion, migration, gene regulation, and signaling. Very important compound for us. It's an important endogenous regulator of the TRPV1 ion channel, which is involved in pain and inflammation. And also, it's an endogenous regulator of the glutamatergic receptors, which is involved in neuroexcitation. And what's interesting here, too, is that you'll see, again, it was somewhat homeostatic for some of these patients. So for the patient A2, very high levels before cannabis, brought down to a lower level with medical cannabis. A9, as you can see, somewhat corrected in these as well. But interestingly, again, the older children had very high levels of this, not all of them, but 3 out of the older children, very high, almost, I think, 27 or 30 standard deviations away from the mean, brought to much closer, shifting towards that typically developing physiologic range. So I hope that makes sense to everybody. And then what I'm showing you here is just 3 of those older kids. And this just looks a little bit different. So you can see the metabolites are listed on the left. I'm sorry, it's hard to read them, but these are basically just our codes for them, like CAN 1, 2, 3. And then physiologic range, -2 to +2 is that physiologic range with the mean down the middle. And what you can see is all the various metabolites that are kind of out of range, so greater than 2 standard deviations away from the mean, and many of them greater than 4 standard deviations away from the mean. And when plotted this way, it's just a nice visual to see what happens when medical cannabis is given. This is after their medical cannabis, that shifting, and it's not perfect, right? It didn't correct every metabolite, but certainly this correlates, this shifting towards the physiologic range correlated with those behavioral reports, what the parents are telling us in terms of aggression and more of a more balanced, calm state. Now, what are the applications? So we have predictive, so we can measure if a patient might benefit from medical cannabis treatment. I'm going to show you that next. Responsive, so quantify the response of the body to medical cannabis treatment. What is it doing to any particular human being? What is it doing to their N-acetyl aspartic acid? What is it doing to their spermine? What is it doing to their endocannabinoid system? We also know it can be used in pre-dosing, suggesting dosage and active ingredients to at least initiate the medical cannabis treatment, and I'll show you that as well. We can use this testing to monitor serially to assess the status of a disease or medical condition, and also potentially use this for diagnostic. We did find one lipid that was present in children with autism that was not present in the children with the typically who are typically developing, and potentially this may be a diagnostic biomarker for autism. So here's a heat map of a number of the children, and you can see across the top, A18 I think is here, and some of the other kids. Here's the typically developing, and again, so using the key at the bottom, optimal is that very tight control between 0.05 standard deviations away from the mean. The darker blue is the physiologic and the red is symptomatic. And as you can see, this first patient listed here has quite a bit of kind of out of the zone biomarkers. And the likelihood of that patient to benefit from medical cannabis treatment based on our calculations is about 93%. So that could be quite helpful for a family who's deciding where to put their resources. And then you can see for A12, this child was really before, this again is pre, so this was before medical cannabis. They looked that they were mostly in pretty good shape. They really didn't have too much to correct here. And the question becomes is if there's a response of 48%, does somebody want to delve in? But I think this is very helpful to at least advise people prior to delving into medical cannabis. And then for pre-dosing, so we can collect saliva before initiating that treatment, right? Which is what we did with our patients. They were already on treatment, but this is what we can do in future. And we can compare it, their baseline heat map, so to speak, compare it to profiles that already exist in the database, and we can initiate targeted treatment. So here is a child before their medical cannabis. This is their map of their metabolites, and we can then look for that within our database, and we find somebody else that's very similar. Doesn't have to be exact, but very similar. And we know what that person is taking, their regimen that gives them these results optimized. And then we at least have some way to not do the trial and error. Oh, I think you should start with this or that, depending on what physician you go to, their clinical experience, and so on. This could be based on a previously established response. And then we can repeat to assess the response and target these uncorrected biomarkers. So there's a lot of value, I think, in doing this. And then our third paper, I'm not going to go through the second paper because it's similar to what I just showed you, but this third paper is machine learning approach. And so what we did was we took our data, and we had a lot of data, and we decided to have machine learning evaluate it. So our data included 3 categories of children. So we had our typically developing children, we had our children with autism before they took their cannabis and that set of metabolites, and then we have our children, the metabolites after they took their cannabis at those peak levels. As I mentioned, we had 484 known metabolites with 65 identified as autism cannabis responsive. And then we used only 3 of the cannabinoids where we had the most robust data. Remember, the CBN, THCA, and CBDA were only being used by a few children, and we felt that data would be somewhat confusing for us to include that since we did not have enough information. So we just really looked at THC, CBD, and CBG. And just to say, we used to talk about THC and CBD as the main cannabinoid. CBG has kind of fallen into that category now. It's kind of the 3 main cannabinoids that are being used quite a bit by both medical patients and those who are just self-medicating. And so if you're not familiar with machine learning, it basically gives computers the ability to learn and improve from experience without being explicitly programmed. These machine learning techniques have successfully been applied to other metabolomic studies, including metabolic signature of severe COVID, taxonomy of human gut microbiota, metabolic changes in human pregnancy, also early stage bladder cancer, where it can predict with very high accuracy. And so you have to put in the data as numerical scales. So we created these data sets, and as you can see, the participant ID on the left, and then we created categories for the doses that the children were on. So if they had no THC and were not on that at all, they got a 0. If they were on a dose of 0.05 to 5 milligrams, they got a 1. If they were on 5.05 to 15 milligrams, and so on. So we converted our dosing to a numerical scale. And then we also inputted our behavior, or we scaled whether they were improved, partially improved, or if they worsened. And that was all fed into the computer to evaluate. And here are some of our results. So what we found, and so this reflects THC in the patients that were taking THC. This is CBD, this is CBG. White compounds reflect metabolites that are involved in lipid metabolism. Orange are compounds that are involved in neuroactivity, and yellow is a steroid activity. And so what we found was that there were 11 biomarkers that were associated with changes due to THC, meaning chemical pathways that were influenced by THC, not just the receptor where we know, let's say THC works at type 2 or type 1 and type 2 cannabinoid receptors and at glycine receptors and so on. This actually tells us which pathways were affected. CBD had 7 pathways that were associated with a change in the biomarkers. And very interestingly, they're mostly lipids, as you can see here, with 1 involved in neuroactivity, but they were not endocannabinoids. And we know that the CBD doesn't really target the endocannabinoid system. It has some activity as a antagonist or negative allosteric modulator at type 1 and type 2 receptors, but it mostly works at non-cannabinoid targets. So that is something that we correlated and confirmed in our study. We found that CBG actually affected the most pathways. So CBG was associated with pathways that you can see here. And then what we found too was there was no overlap between THC and CBD. And so as a practicing clinician, I will tell you that THC is a very useful compound in my patients with autism. It just has to be dosed properly. I don't let any of my patients be high or stoned or impaired. And it's easy to tell. They get red eyes, they get goofy, or they fall asleep. The parents know when their child if their child is on a dose that's too much. I call that the ceiling dose. And we always stay below that. There's no intention here to make a child impaired. But my point being that everybody kind of focuses, we can give CBD safely to children and we shouldn't give THC. But understand that if you have a chemical pathway that is dysfunctional and THC is what corrects it, there is no reason that we would ignore that, especially under medical supervision. THC is extremely safe, and I have patients who've been on it for 10 years who are thriving, graduating high school, going on to junior college, doing well, and not what you might expect. And again, this is not recreational or non-supervised use. This is highly supervised use. All right, so three CBG biomarkers that were affected by CBG overlap with THC, as you can see here. And then we had one CBG CBD biomarker that overlapped, as you can see here. So meaning the pathway was influenced by both CBD and CBG, or CBG and THC here. And what we found is that CBG resides pharmacologically between THC and CBD, and this supports two other already documented findings in other papers where they reported that CBG is kind of a bridge. It has some overlap with THC and some overlap with CBD, and we were able to find that, which is very exciting for me to be able to support some new concepts in this in the medical cannabis world. Now, this is my last slide. So machine learning also found 7 non-cannabinoid phytochemicals. So remember, in my patients, they're taking what we call whole plant. So they are not isolates of CBD where it's the only compound. They're using whole plant products that have not only the dominant cannabinoids, but some minor cannabinoids, but also terpenes, the essential oils that occur in cannabis, naturally occur in cannabis, flavonoids that occur in cannabis, all these different plant compounds. So our machine learning friend here found 7 non-cannabinoid phytochemicals from medical cannabis that were associated with shifting the biomarkers towards the physiologic range. 6 out of the 7 were not found in the typically developing group. So I'm just going to call your attention to this corosylic acid on the top left under B. Here you can see that. So the first bar is the children who then get cannabis, and then it's the blue bar. So that's their result for corosylic acid. And you can see for typically developing, there is presence of corosylic acid. It must have come from, since they're not on cannabis, some other plant in their diet. But 6 out of these 7, so the rest of them listed here, it was undetected in children who were not on cannabis. So we presume that this is coming from their cannabis medicine. And what's interesting is all of them act as acetylcholinesterase inhibitors, which are being used in patients with dementia to potentially improve cognitive function. And so this is only preliminary research. And so we're hoping that we can continue to go further and expand our database of results so that we can really understand what these compounds are doing. But these are the compounds that were found to potentially work as what we call the entourage, so assist the cannabinoids in some synergistic way to help shift the biomarkers that were out of range back into range. And so thank you very much. And I'm happy to take any questions.
All right. Well, thank you so much, Bonni, for your informative presentation. We will now start the live Q&A portion of the webinar. So to our audience, if you have a question that you'd like to ask, please do so now. Just submit a question in the Ask a Question box located at the bottom of your screen. All right, so let's get started. Our first question here is, what is your personal opinion regarding the treatment of patients with ASD? Which cannabinoid, CBD or THC, is more effective?
Well, that's a great question. And the answer, unfortunately, is that it depends on the person and the symptoms and the challenges that the family is facing. So, of course, when I meet with a family, I take a very detailed history to help me determine what the course may be. I do find that aggression, self-injury, and insomnia are often reported as the reason why people are seeking out cannabis. Most of the patients, and I'll just say 90% of my patients, have explored other modalities of treatment and just have not found good results, or people are reluctant to put their child on a medication that can have some significant irreversible side effects. Again, these are people usually in crisis, and that's unfortunate for most. And often in the cases, again, of aggression, self-injury, and insomnia, low dose THC in combination with CBD. So something like a 4-to-1 ratio, 4 parts CBD to 1 part THC, or a 1-to-1 ratio. Again, starting a very low dose, a dose that I don't think will help is where we start. And then we titrate up so that we are not causing any side effects. And we have the saying, start low and go slow. I'm sure many of you have heard it. But that allows you to titrate up and really limit the side effects so you can see how this individual responds. Because again, we are all unique in the way that we respond to these compounds. If someone doesn't have those difficulties, so the parents say the child's sleeping at night, they're just having a lot of focus issues, a lot of hyperactivity, they're not necessarily aggressive or severely self-injurious, then I will usually start with a CBD dominant whole plant or full spectrum oil extract and dose it by the CBD. And the reason for that is because based on the research that we have, about 50% of children will respond to that, even with severe autism. And we have other studies that more than one studies that have used these high ratio or CBD dominant that show benefits. So we go with what the clinical experience is plus what the scientific research is showing. And we try to rule in or rule out that high CBD, low THC. Just to bring up one study from Israel, they started about 60 patients with severe autism on a ratio of 20-to-1, 20 parts CBD to 1 part THC, and about half responded. And the other half that didn't respond, they added in THC to lower that ratio down to a level of 6-to-1, and another 33% of the patients responded. So some of these kids are going to need that. I don't like to necessarily start with a lot of or with multiple compounds at once. But when a family is in crisis, I will recommend a more balanced kind of a ratio of CBD THC.
Great, thank you, Bonnie. I have another question for you here. If self-harm is not responding to THC or CBD, would you add CBG?
Yes, I would try CBG. There is now there's not a lot of research on CBG, and there's none in children with autism, but people are using it. So I think it behooves us as practitioners to delve in and try to help with the dosing and with the make sure we're managing it well, at least be a partner in that care. So I don't really want my patients going off on their own tangent, treating their children without medical advice or supervision. So I do use CBG. CBG can help with anxiety. And I really want to point out anxiety is one of the main reasons that these patients come to me, in addition to these other challenging behaviors, that the child just is anxious from the minute they wake up to the minute they go to sleep. And CBG clearly has some benefits for anxiety. It has an interesting target of alpha-2 adrenergic receptor, which it appears none of the other cannabinoids target that we know so far. And this has been a target, this target, as you know, helps to lower that sympathetic nervous system activity and can be very calming. It's the target for clonidine and guanfacine, 2 drugs that are often prescribed in this population of patients, off-label usually. And I do find that CBG can help. And remember that in any of these patients, one of the reasons for my research is to understand the underlying, like the baseline chemistry in these kids. But I have seen in some patients, CBG can be extremely helpful for anxiety. And also in about a third of patients, it helps them have better speech. I can't explain why, but it's been reported over and over. A colleague of mine who's a cannabis physician in Peru has reported that patients that he's given CBG to helps with speech as well. So really interesting finding there. However, remember, any of these cannabinoids might ramp up certain behaviors in any one particular individual. Remember too that these compounds are biphasic. So lower doses can give a completely opposite effect than higher doses. CBD can be overstimulating in almost half of the patients who take it. It can actually cause, and in the paper I mentioned where they use the 20-to-1 CBD and then added in THC, they reported a 25% restlessness rate. And I believe that is from that biphasic overstimulating low dose effect. We know CBD in studies can be alerting in low doses, higher doses more calming. So I prepare and manage expectations by saying, if I create a child who's bouncing off the walls more, that is that biphase, that could be from that alerting effect from low dose CBD, and we must go higher dose. It's good to prepare people for that, but CBG can do the same thing. And so just be aware of that. But yes, it can help. THCA and CBDA can also help with behaviors as well.
Great, thank you, Bonnie. We have a follow-up question here. Where would you start with dosing on CBG?
So CBG, it depends, of course, on the child's age and size, but I usually start with just 1 milligram and titrate up. Sometimes in older kids, 2 to 5 milligrams, that kind of range, and then titrate up little by little. There is no, CBD has some evidence for weight based treatment, especially in epilepsy. That's something we do with epilepsy and autism. If you read through the papers, you will see various milligram per kilo per day dosing. We don't have that yet for CBG. So again, I start somewhere. Let me revise my answer: 1 to 5 milligrams, depending on the product that's available for that particular patient.
Great, thank you. All right, we've got time for a few more questions here, so we'll continue. This next one I have for you asks, what other conditions might cannabis-responsive biomarkers be applied to?
Okay, so we are looking into dementia. Remember the acetylcholinesterase inhibitor potential for cannabis and the compounds in cannabis is very exciting. These are drugs that are used in dementia. So there is some already existing metabolomic research on dementia. And so we are actually in the beginning stages of planning a study trying to recruit patients using cannabis for dementia. And I will say that although I'm a pediatrician, I have treated patients with dementia in my practice, and also, unfortunately, some close family friends. And there's no question that it has some clear-cut benefits, especially for difficult behaviors, for sleep, and so on. So I'm very excited to participate in that research. Other conditions where it may be beneficial also include inflammatory bowel disease, because we can look at inflammation and endocannabinoid system dysfunction. And then there's another study that hopefully will be getting approved for looking at some people who have had some bad response to cannabis, particularly what's called cannabinoid hyperemesis syndrome, which is an unfortunate condition that usually occurs with chronic heavy use of THC. It doesn't occur in everyone, just in some people. So what we're trying to sort out, hopefully in this study, is to sort out what is happening biochemically in these people who get this, and why does their body have this response.
Great, thank you. Now, what were the limitation of these, what were the limitation of these studies?
Okay, so great question. The limitations are, of course, it's a very small study. It's only 15 patients. And so certainly this does not reflect the population of all children with autism. So this is why more studies are needed, and we're hoping to do a much larger study as well. Really, I'd like to see at least 100 patients or more to be able to help build out that robust database so that we can really understand what's happening. Another limitation is that these patients were already on medical cannabis, and one could say, okay, you already knew that, this is why the biomarkers shifted, is because we already knew that we already saw the manifestations, the parental reports were that these children were responders. So I think it would be important to do a study where we actually get baseline before anybody starts medical cannabis, maybe 2 to 3 months in, 5 or 6 months in, and really look at with the different compounds, how they affect the various metabolic pathways. I think, but in this particular study, we wanted to validate what the parents were reporting, and also to see which metabolites were being affected by which cannabinoids.
Now we've got time for one more question here, so we'll wrap up after this one. And this question asks, how might measurements of cannabis-responsive biomarkers change the clinical practice for a cannabis specialist?
So I think it would be really helpful to have this data so that, again, it would depend on having this robust database so that you could compare. But also, if we understand, let's say a child is already in an optimal range for a particular metabolite or metabolites, we would not necessarily need to target those. We don't want to shift them out. And by the way, none of our patients showed really any shifting away from the physiologic mean. So it kind of shows that this is somewhat safe. We're not harming these children. But I think for my practice, if somebody could come with testing or I could test them before initiating treatment, we would have an understanding of which compounds to start with and also which compounds, and then of course, following up monitoring. Let's say I do another saliva test 2 months in, I can see what do I need to target now? Do we even need to add any more cannabinoids? Do we need to focus on a secondary or a layering treatment? And that's what I do in my practice is, again, I kind of rule it in or rule it out. And if somebody says to me, oh, my child's doing really well, I don't want to do anything else right now, I think it would be really fascinating to be able to compare what they look like on that day when the parent says things are great compared to where they started. And then also, I just want to throw in there, boy, puberty rocks the boat for a lot of conditions for my patients. So both epilepsy and autism, puberty can really change things. And it would be helpful to have some of this data during that time when the patient is showing some difficulties.
Great. Well, thank you, Bonnie. That will conclude our session for today. So before we go, do you have any final comments for our audience?
No, just thank you so much for listening. And also, just one more time, the articles are free online. They're open source, so feel free to take a look at them.
All right. Well, thank you again, Bonni Goldstein, for your time today and your important research. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand for 1 year until April 17th, 2025. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.